Bismillah ar-Rahman ar-Rahim. Welcome to the second session of our meeting today. This session is titled Quantitative Solutions in Clinical Practice, and it will be shared by myself, Dr. Raida Sadham from the College of Dentistry, King Saud University, and by also joining me in sharing this session, Dr. Arij Al-Wabil. It's my pleasure to introduce our first speaker, Dr. Abdurrahman Al-Ghamdi. Dr. Abdurrahman received his Bachelor of Science with honors in electrical engineering from King Saud University, Riyadh, Saudi Arabia, and received his master's and PhD degree in electrical and computer engineering from Purdue University. He held several internships during his undergraduate students with Saudi Aramco and the SDSC companies. He worked as an instrumentation engineer with SABIC, then joined the Department of Electrical Engineering at King Saud University as a lecturer. He has also worked at Qualcomm Technologies Incorporation as an RFIC design engineer, working on the state-of-art 4G and 5G integrated transmitters. He has published in multiple conferences and journals with research interests including RF analog integrated circuits design and microfabrication techniques of novel biosensors. Dr. Abdurrahman will be talking about towards a real-time single-cell measurement using planar RF sensors. Dr. Abdurrahman, تفضل.
السلام عليكم ومرحب في الجميع. Thank you everyone for attending this session. So today I would like to entertain you about the topic of towards a real-time single-cell measurement using a planar RF sensor. Let me start with an outline. My outline will be introduction and motivation about the topic. Then I will move to about one slide to show you the prior knowledge in this area. I will propose show you my proposed work and my results, and I will end with the conclusion. I would like to disclose that this work has been published. So if you are interested in the more details of this work, you can see the paper in the bottom. Also, I think my presentation is towards more kind of a technical background. So if it's will be overwhelming for the other attendees, so at least you will see how an electrical engineer sees biology or sees a single cell. Why single cell is important? This topic kind of came to me back in 2017. So I came across this review paper in Nature. It was reviewing single cell biology. Kind of the main two messages that I got, or 2 points that I got from that article, was kind of a difference between cells in heterogeneous tumor could guide to a treatment. So kind of there's a goal that is kind of is set here. The other one, kind of there's a need to categorize every source of cells in the human body. So we would like kind of to have a library for the human body, kind of categorize every cell in it. So if we look back to the cell biology operation, they are merely 3 operations. They can be sensing and categorization, can be also in other areas trapping the cells. The third one, kind of sorting and separating different type of cells. If we just focus on sensing and categorization, there are broadly 2 areas. One, we can classify them as biochemical techniques and biophysical techniques. Biochemical techniques, basically they are fluorescence-based or kind of electrochemistry-based, affinity-based, optical-based. And most of those, they rely on biomarkers or labels. On the other hand, biophysical techniques are kind of targeting the intrinsic characteristic of cells, for example, mass, density, size, height, molecular composition. So in my topic, kind of I focused on two two main areas, which are the size and electrical properties, for example, conductivity and permittivity. So kind of to get everybody on the same floor, like kind of we have to go back and review what are the three common aspects of the cells that kind of they share among them. So either way, it is a prokaryotic cell or a eukaryotic cell. There are kind of three main points. So the first one, kind of every biological cell has a thin plasma membrane. This is usually in the range of 3 nanometer thick. The second aspect is kind of the cytoplasm. So kind of all the kind of, the will be the DNA, the area that contains the DNA. So that would be kind of the nucleus. The other one kind of would be the cytoplasm. So everything other than the DNA, that the area that contains the DNA will be called like cytoplasm. As an electrical engineer, we look at this as kind of basically two spheres. So the bigger sphere will be that contain the plasma membrane will be a capacitor, and a leaky capacitor, a leaky resistor. So the resistor will be will kind of explain the ions that travel back and forth through the membrane. We have the cytoplasm. Mostly it is conductive. So we kind of model this as a resistor. And inside the cytoplasm, or the area that contains the DNA, we will have the nucleus, and we model that as a capacitor and resistor as well. So to understand kind of what are these capacitances, there was a work done by Sean in the 1950s. So they have kind of measured across all the frequencies, and they have kind of came to a conclusion that we see three dispersion or relaxation when we measure a cell. So there are kind of three regions. We have the alpha dispersion, which is about a few hundred hertz. And this is kind of, for an electrical engineer, is kind of the bottleneck of measuring the interior of the cell. So because if you have the electrode and you have the cell, then you form an electrical double layer capacitance. So this is kind of a problem. Then when they kind of introduce the megahertz and gigahertz frequencies, we start to kind of go inside the cell and can measure like more details of it. So in the beta dispersion, which is about megahertz, we can kind of conclude or read the cell membrane capacitance. If we go to the alpha dispersion, which is a few gigahertz, then we can measure the cell cytoplasm. So knowing these frequencies and knowing these kind of dispersions, and we have kind of the most complete model that we introduced in the previous slide. One can kind of select the frequency of operation, and then they can reduce or simplify more their model. So on the left, kind of, if you're going to excite your system at a megahertz frequency, then you will be able to measure kind of the cell membrane capacitance, also with the cytoplasm resistance. If you would kind of excite the system at a gigahertz frequency, then what you will be able to read is kind of the cytoplasm capacitor. So to read that, we will need kind of, as I mentioned before, like in the previous slides, that I would like to use an electrical method rather than an optical method. So for an electrical method, then I will need to have a sensor that can measure these capacitance for me. So the sensor that was introduced is what we call a coplanar waveguide. So basically, it's kind of 3 strips of gold or metal lines, and then kind of we introduce kind of about a 5 micron spacing between those electrodes, and then we try to kind of trap the cell in between these regions. So before doing that, kind of we need to characterize our system to make sure that, for example, here I use this is kind of a classical electrocode that's already have been published. and kind of the one the right is kind of the proposed one. So I just kind of fabricated both devices. Then kind of we measured those devices to confirm they are kind of they would work as a capacitor that we can measure for our measurement in the next step with cells. So we measured first of all in dry condition, and we can see kind of these capacitances. They are about almost kind of 1 femtofarad difference. So they act as a capacitor from this graph. Then kind of we move to bring the cell to the electrode. So for example, if you look at the picture on the left, kind of it will be very hard to direct or trap a cell in between those electrode without kind of having a third control technique on this. So what we propose here is kind of to have to introduce a microfluidic channel. So this channel kind of would target or kind of to have an inlet and outlet. So that would direct the cell to move from one port and then will be trapped to this area. To do the trapping, we introduced another technique, which was kind of micro pillars. So these kind of basically about kind of 3 micron by 3 micron pillars. They are kind of standing in the flow, so that they can stop a cell, or they can trap them with just kind of stacking in between them. Here in the picture on the right, you see kind of the microchannel is kind of aligned perfectly as fabricated here. Then you can see kind of how the cell they are moving. They can be captured in between the opening here. Then kind of we measure these under different conditions. So for example, the first condition kind of measured under kind of cell media. So basically the same solution that we suspend our cells in, we just kind of measured with only the media. Then we introduce another sample where we have the cell media and the cell suspended in the cell media, and we measure again. And kind of the third test case was kind of to leave the cell media and the cell to dry by forcing heat on the structure. So then we measure our sensor. So from these measurements, we kind of have the same shape that I showed kind of in the previous slide. So we know it is still a capacitor, but we can see there is some fluctuation between the model and the measurement. So from that, kind of one can extract more information, for example, the conductivity. And this is kind of done by kind of modeling the measurement that we have these curves, fitting them to another model. So the model that was used, for example, for now was kind of to extract only the capacitance. So we have kind of, this is the model here. We have transmission line. We have our sensor as a capacitor, a variable capacitor. And then we have this kind of parasitic effect that happens with the system. Kind of, if you look at the table here, we see that the sensing capacitance under the media is about 3.7 femtofarad. Sensing the capacitance with cell media and a few cells, that turns out to be 4.2. Sensing capacitance under the dry condition kind of reduced to 2.1. The conclusion that we can see there's a difference between cell media and the cell. So that kind of gives us a hope that someone can measure a difference in kind of in real time. That would be the kind of further it would be very satisfying to measure a different type of cells as well, and to be able to differentiate between them. So in the next slide, kind of I will just show kind of what this work has done compared to other work. In terms of kind of the novelty, this design was kind of introducing a microchannel that is 50 micron wide. This has kind of improved our sensitivity in the system, and kind of brought this microchannel much closer to the electrode, despite the small size. These other two work, they show 100 micron and 150. When you compare those kind of 150, that means that you can have like 3 cells, they can be moving at the same time, and we wouldn't be able to kind of trap one of them. Instead, kind of if you make it narrow, you would be able to trap cells easily. The third kind of, or second, or the third kind of novelty in this design, this is kind of the microchannel was fabricated using photolithography techniques. So there was no need to kind of make your channel and kind of integrate them manually by hand. So that was kind of only done using using kind of a photolithography technique. So that's kind of more, I would say, accurate. Third novelty in this design was to introduce the micropillars. Other techniques kind of in the past, they used C-cup, but when you use a C-cup, you turn into the problem of clogging the system. So in order to reuse your system, then you have to kind of clean it completely. So in conclusion, kind of this novel structure allow you to measure kind of individual cells. Also, kind of this microfluidic channel is integrated with the RF sensor. We have done kind of measurement with live cells rather than beads or dead cells. Although kind of the difference capacitance that I measured was very small, but it is, I mean, in agreement with it is available with other techniques. This is kind of a list of my references. And you have any, thank you for your listening, and if you have any question, please ask.
Thank you, Dr. Abdurrahman. We have time for questions. If you raise your hand or type any questions, we can entertain them. دكتورة أسماء تفضلي.
السلام عليكم.
وعليكم السلام ورحمة الله.
Shukran, Doctor, for this very interesting presentation. To be honest with you, when I first read the title, I thought it was going to be very technical and difficult for us health professionals to understand, but you explained it very nicely. Thank you very much. My question is, have you worked with biologists or pathologists who have started implementing your technique in their work?
Actually not. I mean, when I actually most of this work, I did it during my PhD. So I had to kind of take cell culture workshops and have to kind of do most of the cell culturing myself. But I'm very actually open to replicate my work with different designs at KSU. So if there is any kind of opportunity for collaboration, I will be open to it.
Yes, and I'm pleased to see that we have among our attendees several names that I do recognize are pathologists. So I hope that this will encourage collaborations between you. Thank you.
Thank you.
شكرا لكم. شكرا دكتور عبد الرحمن.
شكرا.
Assalamu alaikum jami'an, and thank you Professor Raed and Dr. Abdurrahman. Our next session is titled Quantitative MRI Imaging of the Brain, Fundamentals, Techniques and Applications, and our speaker is Dr. Abdullah Boujameh. Dr. Abdullah is an associate professor and consultant at the Department of Radiology and Medical Imaging in the College of Medicine at King Saud University. He's also the head of medical physics section at KSU, and he obtained his PhD in the medical physics of MRI from the University of Nottingham in the UK. We warmly welcome Dr. Abdullah Boujameh, and Dr. Abdullah, the virtual floor is yours.
السلام عليكم ورحمة الله وبركاته. الله يسعد مساكم جميعا. أتمنى يكون صوتي واضح إن شاء الله.
واضح.
ممتاز الحمد لله. So I choose this topic actually because it's one of the important topics or the hot topics nowadays, especially with the introduction of artificial intelligence and using artificial intelligence in radiology. So quantitative MRI is really one of the things that will help to utilize these technologies in radiology. So let us start with differentiate between quantitative and qualitative MRI. So if we look at the difference between them, let me just try to. So usually quantitative data, they have numerical values, they have discrete continuity, they have continuous also, can be counted, measured, factual, compared to qualitative information, which can be felt, for example, or smell, like taste, hear, sense. It's like it's not a discrete values. So people, they can describe this differently. So for example, if we say age, for example, a quantitative value of age like 25 years old, 25 plus 3 months, for example. Qualitative, we can say this is a young man or old man. Temperature, for example, 40 degrees, and is a measurable value, which is quantitative. If we say this is a cold weather or hot weather, this is again subjective, and people, somebody might think this is cold, other person can say this is not, it is hot. Again, like weight, for example, 85 kilogram. Some people, this is a value. We know this is 85 kilogram, but if we choose the qualitative values, so we can see some people, they can say he's a fat person, while they can say he's average. So again, length, other parameters can be again falling in the same description. So what about MRI? Qualitative MRI, actually, it is based on visual interpretation. For example, radiologists usually use phrases like high signal intensity, hyper intensity, low signal intensity, they will say, or hypo intensity, ISO intense, signal void, homogeneous versus heterogeneous, enhancements, ring enhancement, faint enhancement. So all these are descriptive, and people might disagree. And a person might say this is enhancing, the other one, no, this is maybe artifact, or it's not enhancing. While subjective, this is subjective, it's difficult to visualize macroscopic lesion. Again, difficult to assess diffuse or subtle changes. It depends on the protocol settings, depends on hardware parameters such as the magnetic field strength and homogeneity of the static magnetic field, and the type of radio frequency coil sensitivity again. For example, in radiology, they use to assess demyelination, sometimes they use a scale which depends on the number of white matter lesions. So 3 indicating less and more severe white matter. So again, that's, as I said, qualitative is affected by many things. So from physics point of view, we know the RF coils that sometimes vary their sensitivity of detecting the signal from location to another. So if the lesion is located in the area where that signal intensity is low, so it might not be as a high signal as the one where it's located in near the coil high sensitivity. Other parameters like echo-train can affect signal inhomogeneity, and this again will be affecting the signal intensity. All radiologists, they know that there's a difference in T1 images between 1.5 Tesla and 3 Tesla. And that again affect how the tissue appears and how the lesions will appear in 1.5 compared to 3 Tesla. Another parameter is the TR, again, in image contrast. As we increase the TR, we can see the signal intensity is changing as well. many things that affect is, for example, something very simple like image windowing, and windowing your monitor or screen can affect you see, all these are the same image, but are window, we selected different window. So lesions might be very bright in one window and more mild or low in another window. If we go to quantitative MRI, it's based on numerical values. So it doesn't rely on the radiologist eye. You see, that's the conventional MRI, and this is the quantitative MRI. Each pixel has many values to be measured. For example, apparent diffusion coefficient, now it's a standard used in radiologists. They know all apparent diffusion coefficient is number, is not, they call it MAB. They don't call it weighting, because its values can be measured, and when you put the ROI within that area or lesion, you will get a measurement. Similarly, we can replicate this to T1 relaxation and T2 relaxation. We mean relaxation time, not the image, the T2 image or T2 or T1 images. No, this is a T2 maps, means each pixel has representing a T1 value of that pixel, or a T2 or a T1 value for that specific location. There's a comparison between conventional MRI in the top, and this is the what we call quantitative MRI at the bottom. So this is a T1 maps is different than T1 image. T1 maps is represent the values of, so that the bright signal there represent high T1 values compared to the dark, which represent a low T1 value. Similarly, we have a T2, R1, R2, and other parameters also. We will see some of them. So the importance of quantitative metrics in clinical practice, it provides standardized and reproducible metrics, reducing variability and subjectivity in interpretation. Also allow for precise differentiation between normal and pathological tissues. It measures various tissue properties such as relaxation times, diffusion coefficient, and susceptibility, and many other parameters. So we have a lot of information in MRI. We are just utilizing maybe 10% of those information if we are using T1 images or T2 images or proton density. And while if we use the quantitative data, that will be a huge amount of information. Also, that will help us to facilitate the tracking of disease progression, so we can measure those values before the medication and after medication, or just for follow-ups and see how these values changes. But if in qualitative MRI, patient can do MRI in one scanner and then follow up in other scanners, and the image will be completely different. So in 1.5, and he do the follow-up in 3 Tesla. An example of that, I published only a paper on showing how the field strength will affect a small vessel bleeding, for example. It's very affected by 3 Tesla, so it was exaggerated. Patient visit for the first MRI, and it was like 3 millimeters. And then the follow-up, he came and they did MRI in the 3 Tesla. So that lesion increased, exaggerated to 4 or 5 millimeters. So the radiologist thought that this is like increasing in size. And the third time he came and did the MRI in 1.5, and the lesion was shrinking. So he asked me, when I go back, I found that the patient did the MRI in different scanners. And specifically that kind of lesion is affected because it contains hemosiderin, and this is exaggerated by the magnetic field. And we reported this as a case report. So that is the effect of magnetic field. Again, for statistical analysis, those valuable information can be very helpful in comparing different diseases. So an example of quantitative MRI techniques, T1 maps, which is very important in many applications. It is based on what we call inversion recovery acquisition, and that can produce a T1 maps, as we can see there. And an application of that, assessing white matter lesions and quantifying melanin integrity, as you can see in this paper. It can be also used in cardiac imaging to assess a myocardial tissue characterization. This is one of the techniques used in we call it T1 mapping. And again, in liver fibrosis, and also in musculoskeletal imaging, they can measure how healthy or the cartilage and osteoarthritis severity. Another quantitative values is T2 and T2 star mapping. Technique is by acquiring a multi-eco-train T2, and from that we will reduce the T2 maps. Again, sometimes they represented it as colored maps, where the red is the highest values and blue is the lowest values. The main important application is the iron overload, which is used intensively in assessing liver iron quantification or iron overload in the liver. Again, this is a discrete values. So by measuring those values, we can see patient has a severe iron overload or no iron overload based on those values. Another well-established quantitative technique is the diffusion imaging, which we use daily in our scanning. And radiologists usually they use ADC maps to assess the restrictions of the lesion, and those values can be measured in MRI. Another quantitative technique is called magnetization transfer, and this is based on the energy of the protons. And again, this can be generated, and this is an example of images we did for multiple sclerosis. And as you can see, sometimes it's really helpful to see the maps for those kind of magnetization. Also quantitative susceptibility mapping, which is based on the susceptibility content of the tissue. And again, this can be an important parameter in just to give you an idea about other techniques that we use daily, and they are quantitative and they can be translated to numbers. For example, MRI spectroscopy is that we can measure the peak strength of the values or the ratios. From the spectroscopy, we can get many quantitative data that can be also representing tumors or the type of the tumor, or whether it is malignant or benign. Recently, another techniques like intravoxel incoherence, or IVIM, it is based on diffusion again. Again, it has many applications in tumor characterization. Again, diffusion, as I said, has many parameters can be driven from diffusion. All of them are quantitative and can be measured. Dynamic susceptibility, contrast perfusion, again, is one of the well-established techniques. Again, it is based on a quantitative parameters. So we do the perfusion, and the resulted maps, we have many maps. One of them is the cerebral blood volume, and that map can be again measured. And the radiologists usually they compare the values of the tumor compared to the normal tissue. And this is an example of again the values that can represent low-grade glioma versus high-grade glioma. Another perfusion also can a different type of perfusion. Again, as you can see, those values is very important to characterize the kind of the. So those values in total can be, if we can tie them all together, we can produce what we call multi-parametric quantitative MRI. So if we can fit all these information to the computer with the help of AI in the future, I think in the near future, we'll be able to diagnose more accurately. One technique is used now commercially is a synthetic MRI, where it is producing both quantitative and qualitative images. And this technique, again, it's based on applying an RF pulses with different flip angle or different inversion recovery pulse. And from there, they can calculate both T1 and T2 and generate the quantitative maps that we said R1, which is a T1 and T2 proton density. And then also we can generate the conventional images, which is a T2, flare, stare. And so the advanced quantitative MRI technique, like synthetic MRI, will be more efficient, more versatile. It is more cost effective because it's a one sequence, you run it, and then you can acquire many information from that sequence. As you can see, this is the in the top, the one is the conventional MRI, and this is the one in the top, in the bottom is the synthetic MRI, where all contrast can be generated from one acquisition. But there's the challenges that it is technical complexity, interpretation and familiarity from radiologists, also standardization between 1.5, 3 Tesla and other parameters. Application is tumor assessment. You can see that it can, as I said, we can have many values driven from that technique, and we can compare it statistically. Another application is in neurodegenerative diseases. Again, we have many maps that can be used, plus the values that can be used. And one of the application that we have one paper for publication using T1 and T2 maps just to compare with image enhancement in MS, in multiple sclerosis. So how quantitative MRI will improve diagnosis and treatment? It's enhanced sensitivity and specificity, and it will be improving, guiding the treatment, monitoring treatment response, personalized therapy planning, and case study demonstrating effectiveness. Emerging technologies like artificial intelligence and the image analysis can help. And for example, this patient follow up like MS patient, we know they follow up every year, and then from year to year, we can calculate how patient is getting worse or stable. Hybrid image, again, techniques like PET-MR can benefit from these techniques. Potential researches like new biomarkers for neurodegenerative disease, improve protocols for standardization, and improvement in image acquisition and processing. So in conclusion, quantitative MRI is increasingly utilized as complementary to quantitative MRI. It offers significant advantages in terms of objective assessment and detailed tissue characterization. It is contributing to improve diagnostic and treatment planning. However, challenges related to complexity, standardization, and interpretation must be addressed to maximize its potential in clinical and research settings. These are some of the references that I used in my presentation. Thank you very much.
Thank you, Dr. Abdullah, for this very fascinating presentation. We do have a couple of minutes before we wrap up session 2, so we invite audience members if you have any questions. Dr. Sakhar, please, the floor is yours.
Thank you so much for your kind presentation. It's very nice. I really enjoyed it. I was wondering, when will this be available in clinics? Because usually would the radiologist provide the doctor with a report, or you envision that they would provide the doctor with a report? Because the consultation time with the doctors are like 10 to 15 minutes maximum. Would that be helpful to them, or how would that work in your vision?
Yeah, thank you for the question. I agree with you. Usually, there's a resistance for anything new. So radiologists tend to, based on the conventional way of assessing images, based on that, it takes time for them to go and measure the values. Although this is really available and it's already in most of the conventional scanners, it's there. But I mean, maybe within a few years, it will be as something that is based on the scanners to interpret these images and give the radiologist the final report, so he can refer to the values rather than images.
Thank you.
Yeah, welcome.
All right. Well, thank you so much, Dr. Abdullah, for your presentation. And we also thank our speaker, Dr. Abdurrahman Ghamdi, for his presentation in session 2. This concludes the second session of the scientific symposium, and we transition now to the third session, which is co-chaired with Dr. Adil Zahrani. In this session, it's titled Wearable Devices and Internet of Things, in which we look at the first topic of IoT in home care management systems using cardiac arrhythmia deep learning classification. And the speaker for this session is Dr. Arij Al-Mazrour. Dr. Al-Mazrour is an assistant professor in the computer science department at King Saud University. She earned her PhD in artificial intelligence from Durham University in the UK. Her research interests are Internet of Things, artificial intelligence, cybersecurity, e-health, and smart homes, and she seeks to integrate cognitive learning in her research to apply innovative solutions to critical areas such as healthcare and smart environments. We warmly welcome Dr. Arij Al-Mazrour, and Dr. Mazrour, the floor is yours.
Hello, everyone. Thank you very much for this opportunity, and thanks for organizing such a great conference. First of all, I want to make sure as my slide appear to you all.
Yes, it is. Thank you.
Okay, so let us introduce my topic. I'm going to talk about an Internet of Things home care management system using cardiac arrhythmia deep learning classification, which is a part of the integration between the medical department with the artificial intelligence together in helping patients to have a pleasant life in their life. So first of all, let me talk deeply about Internet of Things. Internet of Things, actually, it is a new technology that is one of the most important technology nowadays. It attracts also researchers. It is talks about how we can embed devices and equipments with sensors and then integrate them all together in a network, so it can help us to rely on them, to do some to rely on them and to help us in our daily life and to reduce the human exertion. So my topic is about designing an IoT home care management system. This system will be able to monitor the patients and elderly while they are at home, and also for providing them with the best diagnosis and comfort living, while in the same time it produce accurate results. So first, let me describe what is ECG or electrocardiogram. I think most of you you know this signals. It is like a recording of the heart status. Actually, we are using these signals to manage the patients, to check their heart status, The system was built using 2 stages, the feature extraction stage and the classification stage. In the classification stage, we apply deep learning, especially one of the artificial intelligence technique to increase the accuracy of arrhythmia classification. So the proposed model, it talks about taking the ECG roll signal. Actually, it is from an online database available for everyone. But the problem with those signals, it contains a lot of noise. So we have taken those signals and then we did some signal filtering for them to make them clear from noise. After the signal filtering technique, we passed them through the feature extraction stage. In the feature extraction stage, some features were extracted, which that help us in diagnosis the patient based on their heart problem. Then we keep this for the deep learning, and the deep learning classification stage is starting later. So based on the classification, we were able to classify each signal into normal and arrhythmia using, of course, artificial intelligence technique. So for the ECG signal, usually the ECG signal contains of 5 main waves, and the starting of each wave is very important to measure how the heart the health of the heart is okay or not. So let us start with the P wave. The P wave is the atrial systole contraction pulse. The beginning and the end of that wave is so important. So we were able to detect that wave and to make sure is it with the normal range or not, to make this signal, is it go to the normal as a normal or as arrhythmia. Then we have the Q wave, which is the downward deflection that's immediately preceding the ventricular contraction. Then we have the highest amplitude, which is the R wave, which is the peak of the ventricular contraction. And then the S wave that goes down again, which is the downward deflection immediately after the ventricular contraction. And lastly, the T wave, which is the recovery of the ventricular. So as I mentioned before, the beginning and the end of each wave here, detecting those waves is very important in our model. So for the signal processing technique, we used a low pass filter. In the low pass filter, we put the signal in lower frequency, then attenuated to higher frequency. Actually, the benefit of this filter is to remove the noise that makes high frequency component from the signal, and also to remove any external interference that affects the signal as well. And then the third stage is the feature extraction stage. In the feature extraction, we have 4 main features, which is the QR complex, which is the time interval between the Q and S wave, and also it is measured in millisecond. Then we have the second feature, which is the RR interval, which is the distance or the time interval between the beginning of 1 R wave until the end of or until the beginning of the second R wave, and we are measuring both R waves adjacent to each other, and also it is measured in milliseconds. After that, the heart rate feature also is calculated, which is which is calculated by dividing 60 over the R interval that we have already taken it from the previous feature. Then lastly, we have the QT interval, which is the time interval between the starting of the Q wave until the end of T wave, and also it is measured in millisecond. So for the classification, here we have applied one of the artificial intelligence technique, which is the deep learning. It is used in our model to raise the accuracy of arrhythmia and also to minimize the human efforts. For the deep learning, we have used the MLP, which is a multi-layer perceptual neural network, which is a class of feed-forward artificial neural network. This neural network is based, or it is worked by having each node as a neuron, and that each node will be used will apply an activation, a nonlinear activation function in each one of those neurons. Then the MLP will be used as a classifier for best cardiac arrhythmia classification. So by using MLP, we are able to classify the signal into normal and arrhythmia. And then we can differentiate the data. The most important thing with MLP, it can differentiate between the data using nonlinear separation. For the experiment results, our simulation setup was built using 48 ECG signals that were taken from the online database, which is MIT BIH arrhythmia database. And also there is another 18 signals were taken from the same database, but it is classified as normal sinus rhythm database. Both signals were digitized at 360 samples per second per channel, and the simulation was built using MATLAB. First of all, let me introduce to you the results. For the ECG signal of the first patient, you can see this is one of the ECG signals. As you can see, the waves are clearly shown. It is plotted on samples per amplitude. But the problem with this figure, there is a lot of noise, and the beginning and the end of each wave is not clearly shown. So that's why we are applying some filtering technique. So this is the signal processing technique that we have applied, which is low pass filter. As you can see here in this figure, in comparison with the previous one, it is much clear, and also the beginning and end of each wave are smooth. After this step, we are able to extract the feature and detect the waves by starting at the ending of each one. So in the feature extraction stage, you can see here in this figure, the same patient, we were able to extract the waves. As you can see, there are a red sign for the R waves, also the green for the beginning of the P wave. The green squares the beginning of the Q wave, the blue square the beginning of the S wave, and then lastly the pink triangle, which is the beginning of the T wave. So based on the extracted waves, we were able to calculate the features. As you can see here, the QRS was for that patient was 38 milliseconds. The heart rate was 100.1 beat per minute. Then the RR interval was 594 milliseconds. And then lastly, the QT interval was 237.60 milliseconds. For the artificial intelligence, after applying MLP decision boundary, you can see here in this figure, there are two parts, which is the red part and the green part. Here we can see we were able to differentiate the data into two parts, the normal parts and the arrhythmia parts. The yellow dots represent the normal patients, and the blue dots represent the arrhythmia patients. The most important thing with the MLP, it is this non-linear separation between the two classes, which is very important and makes the decision accurately differentiate between the two classes. So for the setting of the MLP, I was able to apply this MLP using 2 hidden layers, and there were 10 neurons in each layer, and the learning rate was 0.15. The number of epochs were 500. For the input, we have selected 2 features, which are heart rate and QRS. For the output, as you can see, the output, the green part was the normal, and the green part, sorry, was the arrhythmia, and the red part was the normal part. To make sure are we going in a right direction or not, the most important feature in any medical application is the accuracy. So we need to measure first the mean square error, which is calculated by specifying how many errors can be detected by after applying the artificial intelligence. So by using 180 epochs, the mean square error for our model was reaching a number close to 0, which means the number of errors are very limited, and that means it produces very high accuracy. And then to compare our work with the previous work, we have chosen one of the papers that goes maybe let us see how we compare our work with them. They have used the same for training techniques. They are using Python. In the other word, we used MATLAB. For the classification technique, we use MLP, but they use MLP as well with CNN. For the hidden layers, we both use the same hidden layers, 4 with 60 neurons. For the activation function, both of us, we used sigmoid. For the classification accuracy, they produce 69% for the first 100 epochs, while in our work, we reached 87% for the first 100 epochs, which mean our model outperformed their work in accuracy. For the database, we use the same database, but they use another database in addition. Also, it is available online. For the classification of data, we are using the same classification technique, classification parts, which is 80% for training and 20% for testing. To compare also our result with their result, we have tested the normalized mean square error. As you can see here, the normalized mean square error for our work and their work, the blue it is for our work, and then the red one for the previous work or their work. As you can see, after the first 100 epoch, our work reaches around a number reach 0, but for them they reach around 70% which is which means our work outperform them in kind of normalized mean square error. For the accuracy, in comparison between our work and their work, the blue line is for us. As you can see, after the first 100 epoch, you can see our accuracy reaches around 87%, which is outperform their work, which is around 67%. For conclusion, as you can see, deep learning improves the accuracy of home care management system. Of course, nowadays, a lot of researchers talks about deep learning and how they help us in manage our daily life, also and reduce the human exertion. Experiment results shows that our model is more accurate than others in detecting of cardiac arrhythmia. Also, the future work will involve testing the proposed algorithm on a huge and new database. Also, we look forward to apply our model on real patients here in Saudi Arabia in the hospitals to further improve the classification accuracy. Thank you very much for listening and for the opportunity, and hope you enjoyed my presentation.
Shukran, Doctora. Thank you very much. And we'll transition to the second speaker. However, we remind our attendees that the networking session, the speakers would be available to connect with whoever's interested, and you can present and ask your questions in that session. And with that, I'll hand over to Dr. Adil Zahrani.
Thank you, Dr. Rij. Ladies and gentlemen, it's my pleasure to introduce our next speaker, Dr. Mohammed Ghaith Jamil. Dr. Jamil graduated from Aleppo University, Syria, after finishing his residency in internal medicine at the University of North Dakota. He joined the university as an associate professor. Dr. Jamil finished his pulmonary, critical care, and sleep medicine fellowship at George Washington University. He is board certified in pulmonary, critical care, and sleep medicine. He is a pulmonary critical care and sleep medicine consultant at King Faisal Hospital and Research Center. He is the medical director of the Tele-ICU program, director of the Saudi Sleep Medicine Group, and previous chairperson and director of the Home Mechanical Ventilation Program, King Faisal Hospital and Research Center. Today, Dr. Jamil will be sharing his insight on the future of healthcare, role of wearable devices in patient management. Please join me in welcoming Dr. Mahmoud Jamil. Thank you.
Assalamu alaikum. Dr. Rij, if you can stop sharing so I can share my screen. Thank you. Just give me 1 second. Can you see my screen? Assalamu alaikum.
Yes, we can.
Okay, great. Thank you for the introduction. I really appreciate it. So my talk today, I'm gonna just give a kind of overview about what we are dealing nowadays. It's not Dr. Ari, she did a very comprehensive and very nice work about the utilization of device, how accurate. So the wearable device now, they are beyond just a fitness tracker. Everybody was wearing his just to look into his smartwatch, to look into his step. Now it's like it's becoming more and more complex, that to the level that it's controlling our health, or at least helping the physician to really have good idea, and I'm using it a lot in my sleep patient. As you see, there is now increase in sensor wearable device in the market, and this is from NHS, and published in 2013. And the projection by 2040, we're going to have more than 80% utilization of those devices. And worldwide, you can see there's the population around 8 billion. And there's people using their device, the smart device is 8.46. Don't ask me why. Probably people, they have a 2 or 3 device. In Saudi Arabia, we are one of the highest country, and this by 2021, utilizing the social media. So if you see the market now, the healthcare market for the wearable device is around 16.2 billion. And this was in 2021, and the projection to be up to 30 billion in 2026, and basically, especially in females, might reach up to 50 billion. So this is Femtech, one of the company. You can see there's the market is around 39.3 billion, looking to different aspect of the women's health, and around 16.4% from global market in the world. So smartphones, I'm gonna try just to give you a quick idea about what's those smart devices now doing. Some of them, I think a lot of research to look into the utilization in real life. And nowadays with the AI, it's becoming more complex because all the data is gonna go translated through AI to do analysis of this device. So those becoming more and more, and they're looking actually now for more biological research, and I'll discuss how they are doing this later. Those devices carry different type of sensor and have emerged as personalized digital diagnostic tool from they predict and detect the different change in the physiology of the human being. So all those devices to give you an accurate diagnosis, it depends on how the person using this device. That means the more you utilize your device, the more you get data, and the more people that are using, they were able to get a higher number. With the AI, they can separate patient from healthy, and this is will help us to have a more diagnostic. And nowadays, there is some just few examples from those study and utilizing, you say, acquisition from wrist or finger. And for, like, as an example, early detection for atrial fibrillation or stroke and non-invasive monitor for arrhythmia. Others like physical activity could have also impact on glucose control, assess for patient in Parkinson's disease and neurology, looking to their gait, any change in gait, that's triggered to send the patient to the doctor. That's maybe need to change his medication or augmentation. Other like use also, as I said, in MS, and to look into the amount of steps. Maybe that patient have, if we look at the data, that patient have an exacerbation, and we can bring him early to the hospital. Also, they're utilizing for some liver disease and to look into their mobility, their activity, and some biomarker. Sorry. So other, and you can see there is a different device, either the Diafit, the Galaxy, Samsung. I'm not going to promote any of those devices because this is not the scope of or my job, and I don't have any stock market in any of them. So you can look into here. There's the study. I'm just going to focus the device and what their study was done just in general. Like you see here, the Fitbit and the Woo, and they look into heart rate, energy, and mental issue, and they look into heart rate variability, and this will reflect on stress during the day. Also, they look into mental health and stress management, like Oura Rings, now Apple Watch. They monitor, as you mentioned, your sleep stages, how deep you sleep. And many of my patients come to my clinic and they complain about not able to sleep. And I say, do you have a smartwatch? And I look into this data, sometimes give me a good information that's helped me to better diagnose a patient. But if you look into what if we have a big data from a lot of our patients, and those data, we can analyze it. We give the best care for our patient. We look into heart rate variability, and we look into stress management. If the patient have a lot of issue during the day, we can look into the blood pressure. If there's increasing in some area of during the day, we can do modification for their health and breathing others. For women's health now, there's the WHO report that women have 1.5 times more likely than men to experience anxiety and depression. And the wearable device helping to track their mental health and maybe do some modality early on to help women. So this is an example, and previously, the previous lecture, they mentioned about heart rate variability, and this will give us some data about the patient. Bone health, also, this is another wearable device by Garmin. They look into your step because everybody knows that at a certain age, osteoporosis, osteopenia in female, and they look into how their step, and this is very common in female over the age 50. And this is an example. They put it in your shoes and will tell you about the proper stepping and how many steps, and will give you also how to improve your posture and etc. Blood sugar monitoring. Now the past you have those devices that you can prick yourself and get. Nowadays we have this different device that's through the finger, or you can put it on your skin and do continuous monitoring. And there is so many studies now showing there is better blood sugar control, and everybody knows that this is have at the long term have a better effect on a human being. This is a different device, and one actually study was in United Arab Emirates, and they look into gestational diabetes, and they look into the blood sugar monitoring, which help much better tracking. This is another thing, how to look into some habits, some activity for pregnant women. So wearable device to improve physical activity. And as you see, again, I'll just emphasize that we need a big population, and basically what intervention we the study designed to look into intervention, population, and then who's the control that not using the device, and then analyze the data and get outcome. This is how we're going to utilize those devices, not just, okay, I'm using the device, I don't know if I'm going to get accurate data or not. So they look into those, one study looking to mixed population about activity, and they found that people who have wearable device, they increase their overall activity because they give us, give them a little bit of more motivation. And they look into mixed this in general, the mixed population you can see is increasing, but they look into different pathology in all the adult and obese patients. Same thing, this is also how many movement you do per day and stand up, not only just walking. Also, they look into cardiovascular disease, and this is really promising and advancing technique. Looking into, I will mention next slide, but this is they look into people who have cardiovascular disease versus risk of cardiovascular disease. And actually, you can see here there's increase in utilization in people who are highly educated with and people have higher income than lower income. And they look into also Black people, Hispanic, that are utilizing more than white people. This is only like population-based study. Also for precision medicine and future of healthcare, this is from New England Journal. And basically what they look into different device, either rings, a watch, and a patch, and they start looking into the blood sugar and other your food intake, your blood pressure, your temperature, everything. And they look into different aspect of human being, from stress, anxiety, depression. During COVID, was actually stopped acting those devices at that time. And you can see with the slide, just to give you an idea, that there is a user, and we have to store all this in a cloud, look into the AI, and then include it in medical record, and basically the physician, how to interpret the study and how we can act on it. Just having data is not enough. It's basically how, as a physician, we're gonna react to this, and where the legality, if I have those data and I did not react because I'm busy. So there's a lot of now also study about this part from both aspects. So this is another cartoon tell you about how the data. New England Journal, they have multiple articles talking about wearable device. This is one article talking about in cardiology, and they look into AFib, and they tell you they did the study over broad population, and they look at the graph, tell you how much a patient with AFib he will follow and take care of himself. And you see only during exacerbation, there is high intensity, then the care will decrease. With the new device, you can track those patients for a long period of time. And there's many devices now, as I mentioned, there's those smartphone connected, there's the watch, and there's continuous, and this is different way, either the 30-second EKG or continuous. And nowadays, I think some of the cardiologists probably know about those loops that you can insert it under the skin and will stay up to 5 years. And this will reduce the patient visit because the physician can control it by telemedicine. Again, this is a schematic to tell you how the process needed to be done. Because of sake of time, I'm just going to skip it. But the idea we have to have, if you want your hospital to be up to date, you have to start having a plan step by step from the data that you're going to collect, how you're going to react, how you're going to contact the patient. This is also another sensor that's now under investigation, and those are sensor could be done put on the wrist or around the carotid artery or in the legs, and they look into different cardiac monitoring and give a different diagnostic tool that's help the patient and the physician to give the proper diagnosis. In general, this is only, I'm just going to show you how many devices now available in the market that's been, some of them are FDA approved, some of them not, but the study is ongoing. This is also a study showing that some of they're utilizing it as a preoperative assessment, where they give the advice to the patient, they look into how he is doing preoperative, so it's going to give us possible a diagnostic way for high-risk patient, especially if you work as a surgeon or an anesthesiologist or an intensivist, and expectation what's going to happen after surgery. And this is, again, a cartoon tell you about the step that you can do before a big surgery. And I'll skip for sake of time. This is just a picture of different device. You can have this thing you put on your chest, wrist. You can put it over your groin, and also a vest that you can wear it. Also, now there is study about utilizing those smart watch for ST segment changes. And you can do EKG, and this is you put your watch in different spot, and they compare those with standard, and they found really a good compatibility. Sensitivity can reach 84% and specificity 100% for diagnostic. ST elevation sensitivity was 93% and specificity was 95%. And also for non-ST, the same ratio. Also looking into blood pressure monitoring, and they look into two groups. They divide between control, and a lot of patients, they come to the doctor and they have a problem. They have a high blood pressure during the visit, and basically they found really a good reliability on those devices and to know better way to control the patient. I have 2 minutes, so I'm just skip. This is also a device that you can utilize after ICU discharge and can also monitor the heart rate or AFib and blood sugar, and have a good sensitive, acceptable, good specificity, but not a very high sensitive. And also they look into sleep by questionnaire and wearable device, and they look into the red one about the correlation between less sleep and more delirium in the hospital. So this is for biologic. Now there's ongoing research about different patches that people, they can put over the skin in different area, or the eyes and the movement, and they look into movement. And I will show you this. This is now some of those skin patches. They look into different interleukin-6, interleukin-1B, glucose, CRP. This is give you a continuous monitoring, especially people post-transplant or lung, liver, all this, and cancer. and that will predict if the patient going to get trouble or not. And this is a different stuff. So also this is data analysis. I'm just gonna skip. This is how also they look into stressors, how they look into cortisol and metabolic cycle, and they to predict a patient who is gonna have sepsis early or he have a problem with sleeping. Now, a few terms that you're gonna hear a lot now in the market, the orthosomnia. This is obsessive pursuit of ideal sleep, but this can apply for everything like diabetes. Nomophobia is people become so phobic if they don't have any internet connection. I'm just gonna skip, this is just different device now available market. This is for sleep study. We are utilizing still some of under research, but just I wanna focus on one thing. It's basically the data, how we're gonna store it, how the patient have his privacy, how we're gonna get reliability and data security. So giving that, I'm gonna skip those last slide and give time for question. Thank you so much.
Thank you, Dr. Ghaith. And thank you everyone for joining us today at the scientific session. We hope you found the presentations insightful. And with this, we concluded today's session, and we will resume, inshallah, tomorrow at 9 a.m. For now,